Okay, welcome everyone to the person-centered complex care theme session. For those of you who don't know me, my name is Teddy Marson. I'm one of the clinical academics at Liverpool University and leading the theme. It might be slightly Heath Robinson this session. Let's see how it goes. We've got Jenny and Pallavi on the over here. We're just trying to get Jenny hooked up with the people online. So we've got a hybrid session. So we think we've got about 10 people online. I'll just warn the people online who hopefully can hear me. If Jenny can't log on and talk to you, we will need one or two of you to agree to just facilitate online and do some feedback during the session. We thought that we would keep it really simple and build on what we did just as COVID hit. So, clickaroo, there we go. Right, okay. So, in the December, around the start of COVID, we'd started, or just before COVID, we started to do some prioritization work to try and work out what the partners wanted to address within a person-centered complex care theme. Because if you sit back, you can think, well, actually, person-centered complex care covers the whole of medicine, because as we get older, we've got multi-morbidity and everything's just getting more and more complicated. So we did some workshops just to try and identify what the partnership wanted to focus on. And what we'd like to do in the next 25 minutes or half an hour, I think is all we've got of this session, is to get you to reflect on what we identified as a priority and discuss on your tables whether you think that's still right, whether there are things that are missing or things that you think we should be doing instead. So I'm just going to, over the next minute, just flick through slides, and the slides I'm going to present are on the handouts that you've got. So if you look on the table, you should have something that looks a bit traffic lighty on the table, and that's just the summary slides. Can anyone online hear Tony speaking? That's a bit of a worry. Okay. So it sounds like the guys online can't hear me. That might be good.
Yeah, they can.
I can, but join via Zoom. So there's two portals in there's the Zoom link and there's something else. Could somebody perhaps if somebody put the Zoom link in the chat?
Yeah.
Cool. So the guys online connected. Did the guys online hear anything of what I just said?
Yeah, they can hear you.
They can. Okay, right. So hopefully you got, hopefully the folk online. I think the most important thing I said was that Jenny Downey is going to try and join the group and help facilitate. If not, you'll need to delegate one or two people to help feedback. But we're going to revisit what we identified as priority areas a couple of years ago and work out whether they're still important. So we identified an area around digital healthcare, particularly in kind of gaps in knowledge and understanding that we need to address. So we identified wanting to know about the longer term impacts of remote consultations, etc. Something around the cost effectiveness, and these are all highlighted on the handouts for those that have access. And for those online, I will scroll through these during the course of the session so that you continue to have access to them. So here we are. So we've color coded them. So green means we think we're probably doing some good stuff here. Amber is we're kind of almost in the space, and red, we've not really addressed this area yet. So for example, around digital healthcare, we've not really motored on cost effectiveness. The other fairly big ticket item was around continuity of care. And this was something particularly a number of public advisors understandably felt very, very passionate about how things were coordinated, integrated across different sectors of care between health and social care. You know, does it make sense that people have to attend 5 or 6 different clinics when nobody's coordinating everything. You know, there's lots of issues around coordination of care to address. And if we just jump to the color-coded slides, we've got a couple of orange ones here, and the red ones about providing advice and guidance. And the third area was around multimorbidity and polypharmacy. And if I just jump, so you've heard a bit about some of the work here, I think, from Peter around the Dynarex project. I think, was it the Dynarex project? I've forgotten which one's addressing anticholinergics, but there's some kind of work in collaboration with Kai and others addressing that. Okay. So what we'd like you to do, hopefully it'll work, is to have some discussion on your tables around these areas of priority, and we'd like to mix it up. So the traffic green is we think we're doing some stuff, orange is we're almost doing some stuff, and red is we're not doing some stuff. Yeah, red we've not really addressed. So the question is, obviously, one important question is what should we address? If the team online, if you'd like to start with area 1 as well, please. And I think we've got about 15 minutes. So just before you get chatting, just to be clear, so I've given you an area to start, so it's 1, 2, and 3. But once you've had a chat about your area, then I'd like you to move on to the others as well.
Hi everyone, can you hear me okay? Give me a thumbs up, put something in the chat, or if you speak and unmute yourself, I should be able to hear and we can have our own virtual chat.
Hi,
I can hear me. Great, lovely, thanks very much. Okay, so just to revisit what Tony was saying then, here in person, people are having table discussions about our priority areas, and I'm going to have the same discussions with you guys about the priority areas as well. So just to recap, where these priority areas were voted by yourselves, by our member organisations and public advisors when we met in December 2020 ArcFest. And we've been doing work around these priority areas since then. Where it's green, we feel that we've got pieces of work either through our internships, our PhDs, external grant applications, or other pieces of work that are ongoing and addressing those questions. Where it's amber, we're in discussion, or we've got pieces of work that are in progress. And where it's red, we don't feel that we've got anything in the theme at the moment that represents those questions. So from a member organisation perspective or a public advisor perspective, we would like to know if particularly those areas that are amber or red are still priority areas, whether you have any other priority areas that fit into these sub-theme areas that we don't currently have, so we can just refresh the list that we've got. If there's a lot of feedback or anything from the room, can you please let me know, because I'm able to move out of this room if it's causing a problem or anyone can't hear very well, so please do let me know. Just to visit, our first priority area is in digital health. I'm just going to expand this because I can't see it very clearly to be able to read it. So our first one is, what are the longer term impacts of remote consultations on healthcare provision and different models of remote consultations? Now we have projects ongoing in this area looking at primary care, some pieces of work that are looking at secondary care and paediatrics that are answering these questions, and there are some internships that are relevant to some of these pieces of work. So we have, what is the impacts of remote consultations on access to services considering digital inequalities? Some of those questions are being answered by the work that we've got. That doesn't mean that we can't do other projects if that's a particular area of interest for our members. So please do let us know if these are still areas of interest. Are there effective co-produced solutions involving patients, families, primary and secondary care? This and our remote consultations effective for vulnerable populations are part of discussions that we've got ongoing at the moment across our ARC with other ARCs to look at doing external grant applications. And then the red one, what is the cost effectiveness of digital first approach? We don't have anything in our theme at the moment, or that we're aware of across the ARC, that is looking at that. So please either put something in the chat, or if you can speak, please do let me know if this is an area of interest for you still. If there's new areas within digital healthcare, whether you think the red, particularly the red area, is still a priority.
I was just saying, I do think these are all still priority. And I think in terms of the cost effectiveness of digital approach, I think that does need addressing, because it gives more power to the elbow of the other research if it can be proved that it is more cost effective, and get more support for improving approaches for those people who don't have equitable access.
So you think that cost effectiveness is still a priority? So that's something. Is there anybody online who's interested in getting involved with external grant applications potentially around? Is this a key area for your organisation or anything? Because it's great to know that we've got public advisors who are interested in this area.
Once upon a time I might have, but my plate is very full, so.
Okay. It's good to know that we've got people whose interest is in it though. And in terms of the amber areas that we've got, these are still early areas of development for us.
I was going to add about the red area, the cost effectiveness. As a clinician, that really isn't much of a priority for me, in the sense of the technology is now there. So yes. I'm not really thinking about whether it's a cost effective way or whether it's just the best way for that patient for that particular session. I realise service managers, etc., may still be interested in the cost effectiveness, but I think since that has all now been rolled out, it's less of a question for me.
Okay, I was thinking to know. So for clinicians potentially, sorry, go on.
Sorry, I was thinking more in terms of policy, at policy level, that if any evidence of it being cost effective can actually support its further developments.
Okay, that's great. Anybody else got anything else on that, or any of the amber areas? Great. I'm just looking at the chat. It's good to see that we do have the Northwest Coast Health Economists who we could possibly use to help. Yeah, that would be good to tap into, absolutely, especially for external grant applications. Yeah, so if any of our member organisations were particularly interested in getting involved with the ARC about and looking at external grant application around that area, then we could certainly be helpful in that space. Okay. Now, anything else on digital or any other digital priority areas that maybe we aren't on this list, given that we've got some green spaces? We know that some projects that are ongoing, answering some of these questions. Are there other questions that aren't here that maybe people feel should be here?
Hi,
can I? Sorry,
oh,
we're not
sorry,
doing well at this.
Yes.
It's
I was just going to say regarding.
Go on, you go.
Cheers, I'll be quick.
Yeah.
I was just going to say regarding the remote consultations for vulnerable populations, that I think is a really important priority area for me. I'm forbidden from taking on any more research projects, but I would very happily see that be done.
Great. Something that we're looking at in collaboration with some of our other ARC partners in Plymouth is something to do with remote consultation for people with intellectual disabilities. But that doesn't mean that there aren't other vulnerable populations as well. Sorry, Karen.
Yes, sorry. It's Hannah Maidenheath. I'm in the public health team in Blackpool Council, and I'm the lead for a programme of work with people with what we call on the Fylde Coast multiple disadvantage. So people who are experiencing things like homelessness, criminal justice issues, mental health problems, substance misuse or domestic abuse in combination. And I think it would be really and also that all that work is very much got a co-produced focus. And I think so for me, just that definition of a vulnerable population, I think it would be good to see that see some work perhaps around people experiencing multiple disadvantage. So I think it is really important, because I suppose it would be really important to see that those people aren't being left behind with moving towards that kind of style of consultation. So there may be
that's great,
people in the Fylde Coast who, you know, we've certainly got a research network and things, so it might be that we could link up to see if anyone has any capacity.
Where it's green, feel like we've got something that's already happening in the team. Where it's maybe just questions at the moment. So what is continuity of care? How do we measure it from different perspectives? What's the impact of integrated models of care, and what are the effective components of successful models? We've got some pieces of work happening in the theme in collaboration with some of the other themes in ARC that maybe answer some of these questions, but we don't have a lot in the theme about this. And then where it's red is looking at advice and guidance between primary and secondary care and having an impact on polypharmacy and patient care or use of secondary care. When we originally asked members to vote on this back in December 2020, this was not a high priority, and that's why it's still red. We haven't done any work to prioritise this at the moment, but please let us know if you think that these are still priority areas, particularly if they are amber or red.
Has anybody got any comments about the? I'm not really sure what the red one would like. It may not be a priority area for you. Advice and guidance is something that clinicians in primary care can use either via email, via telephone, sometimes through EMIS, to talk directly to secondary care consultants about their patients. Sometimes it's just a phone call, sometimes it's just an email, but sometimes through EMIS and other systems, there's the ability to connect to secondary care and get advice about the patient without the patient having to go actively to secondary care. So I don't know whether that still is a priority area or not, and the amber areas are still priority areas or not, or whether you've got other areas of continuity of care that you might class as a greater priority. Is continuity still an area of interest generally to people, or to public advisors, or to organisations? Maybe we've had some conversations with some member organisations about discharge pathways and things like that for people. Tony's bringing us back to feedback, so I'm going to come out of this. Thanks very much for your input, everybody. Bye.
We're just going to have just be helpful to just have some feedback from each of the tables and the online group. So let's see how this goes. So, do we have a volunteer from Group 1 to just give us some feedback? Are you in that hot seat, Flavie, or have you? Yeah, so it would just good to hear a bit of feedback.
So we focused quite a bit on digital healthcare. Questions arose. Is it something that we've got to think about? You know, is it more for the younger people? What about the older people? Because ever since we've sort of come out of lockdown, you can see the older people really wanting to go have face-to-face meetings with their. Oh, I'm sorry. Okay. So yeah, we're just talking about whether digital healthcare is for the older people, older generation. Ever since lockdown, a lot of older people have been going back to their GPs, wanting to have face-to-face conversations, but maybe digital health is more for the younger population. There are options for, I think you can actually, a lot of GPs are starting new things where you can actually put in, if you have any issue, you can put in the website, I think e-consult. But what about, again, the older people? How would they do it? But apparently there are phone lines where they could actually call into where someone else would do it for them. But again, how is that beneficial for someone who's really anxious and really struggling, maybe someone who's in pain, for them to pick up the phone and do all of that. So those are some of the questions that we came up with. Anyone else wants to input?
Research, what's going out there, you know, to disentangle it from a research perspective, problematic, and I think we need to be simple first, don't we? Because there's lots of stuff going on. Even some of the terminology we looked at, cost effectiveness of the digital first approach. What does that actually mean? What does it mean to a patient? What does it mean to a practitioner? What does it mean to a researcher? So we were a bit optimistic about sort of the emerging ICSs and some of the work they're doing in this space. I'm thinking of big research opportunities there, so maybe further conversations just through our research development network and sort of where we've got really strong digital.
So it sounds like there's enthusiasm for continuing to work in this area. It's an important area. It's certainly been very disruptive, or we are from a clinical standpoint. It's been very disruptive, and it's not going away. We're trying to work out how on earth we do it best, efficiently, safely. And cohesively across the patch. Okay. So Jenny, yes. So what
Yes.
do the online group have to say?
Hopefully this works. Okay. So the online people said that at a policy level, they still felt that cost effectiveness of remote consultations was important potentially. Maybe from a clinician point of view, it's not as important, because the important question is really about, do people get the right care at the right time in the right way? But then we also had member organisations from Blackpool saying that they really felt that more work was needed around vulnerable populations, specifically around, you know, those with multiple disadvantages, and that's really an area that we should be focusing on. Obviously, we've got our intellectual disabilities work that's developing, but it's good to know that people think that we should be focusing it around other vulnerable populations as well.
Yes, so one of the projects we're trying to get up and running at the moment is with PenArc around digital consultations and people with intellectual disability, which brings some specific challenges. Am I coming through the speaker? You can hear me okay? Yeah, okay. So we'll move to group two. I don't know whether anyone. Ben, fantastic.
Yeah. I think we spent sort of quite a long time trying to understand what we mean by continuity of care. Thinking about, you know, continuity of the person that you're in contact with as part of your care, the kind of consistency of being part of a service over time, but also kind of care coordination between multiple organisations and multiple services. There's lots of different dimensions. One of the things that we were talking about is kind of how the different services and continuity of care can be coordinated across the multiple different issues that people are facing, so multiple morbidities, but also multiple kind of social risks and conditions. And I suppose, you know, part of that, you know, we talked about, you know, previously, we've always had, well, can continue to have, there's been this idea of having a sort of shared care plan across organisations, which has been around for a long time, and but doesn't seem to have quite delivered what we'd want. And the main barriers around that seem to be around still sort of barriers around communication and communication across organisations, and sometimes a switch to sort of digital in that, you know, rather than just on a paper record, hasn't necessarily helped. And there's sort of problems of being able to share that information across multiple teams and multiple organisations to support continuity of care. And I think the sort of things we thought about in terms of how you might do things better in the future. One, I suppose, is you know, shifting the perspective in terms of being able to see continuity of care from the patient's perspective and the involvement of patients and the public in actually sort of redesigning services, which potentially hasn't happened as much as it could have done in the past, is perhaps why things have failed in the past. And you know, thinking of what the composition is of a sort of multidisciplinary team has tended in the past to be quite health focused or just health and social care, when lots of the wider issues are related to the sort of social determinants of health, and bringing that in as part of the sort of multidisciplinary team. So evaluating different kind of composition approaches to sort of integration that have a different kind of composition of those teams, and as part of that, potentially the sort of role of a kind of trusted assessor or coordinator, and who's best placed for that role. There are obviously integrated multidisciplinary team initiatives already ongoing. So I guess that's one place to start. And the work that Roberta's presentation this morning was evaluating an approach to that. And one of the things that they have actually been trying to do, sort of subsequent to that, is to try and broaden the composition of the multidisciplinary team. And that's potentially something then that we could go on to evaluate and understand.
Quite energetic, and I think highlighting the continued interest in this area, and for us to get our act together and think about how we provide a structure to try and help things move forward as we're emerging from COVID. Jenny, did the online group get to question 2? Is there anything to report back from the online group? Okay, so some discussion, but along similar lines, and still enthusiasm for the area. Time is continuing to evaporate. Alan, I'll come around to the back, and you're having some conversation about multimorbidity, and also writing some homework questions for me.
Maybe. I did try to get somebody else to do this feedback, but she totally refused. I was multimorbidity and polypharmacy. Of course, multimorbidity might have been the in word 2 or 3 years ago, but now it's long-term multiple conditions, I think is the phrase now. All of ours, as you can see, are green, apart from one yellow one. So we talked basically about that, which is what effective models of care for managing multimorbidity. In fact, are there any? I think probably the answer is no. Somebody said right at the beginning, it's a cultural thing. Doctor knows best, and probably there are an awful lot of patients who actually do have that attitude, which is a shame, really. The issue should be more questioning. We did raise the issue of consultants, sorry about this, Tony, consultants and GPs not communicating, or not communicating effectively, I perhaps should say. And that brought us a question as well. What is the hierarchy of decision-making with regards to prescribing? Is it the GP that makes the decisions? Is it the consultants? Or does it all just get put into a big dish and sort of, we're around, and next thing you know, you've got a whole packet of meds arriving on your doorstep? I don't know. Shared care records is something that somebody said at the table that is something that would be very, very useful. And I 2 of us, at least in this room, live in St Helens, where we do have a system of shared care records. And I know from a meeting I was in a couple of weeks ago, there may have been others here that were in it. Certainly one person was, she sat with her back to me at the moment. We were talking to people from the ICS about data and shared care records and so on and so forth, weren't we? Yes. So I think that's something that they're going to try and achieve across the whole, certainly Cheshire and Merseyside ICS anyway. I don't know about Lancashire and South Cumbria, but they're going to try and do so. Unfortunately though, although I'm a person who's got my records in there, and I'm quite happy, I don't care who gets it, apart from when I heard this morning the word insurance come up from Peter. Because the last people I would want to know about my multimorbidities would be insurance companies. So that's kind of worrying. Who owns or who has access to that info? And I think that's something we need to ask the ICSs or whoever, how going forward, how private is that? How personal is that? I mentioned Dynerics. I think you mentioned it at the beginning, or Dynerics. Maybe at the next one of these we could do a presentation about that. It's a project that's looking into artificial, what's the word? Intelligence, for polypharmacy for people with multiple conditions. I could say this, I suppose. I'm on 12 or 13 different medications. Can you imagine exponentially the potential ways that they could work together against me, if you see what I mean? I think it would take a human being months and months to work that out, whereas hopefully a computer could do it in a millisecond. And that sort of project, I think, has an enormous value. And hopefully, in terms of this question of managing multimorbidity, that's I think, we have a different impact, don't we? Yeah, so I think that could have a potentially really good impact. And quite proud to say that it's attracted the interest of the Alan Turing Institute. So they're following it very closely, which is really exciting. Integrated care came up, i.e. health and social care, or physical and mental health. Sandra, you raised that some time ago, didn't you? Why is it that they treat somebody who's got a physical health problem and a mental health problem like two entirely different people? As somebody said, what was the phrase you said? Why do they look at just the physical or mental problem? Why don't they look at the whole person? I pray for the day. I've got a son with a learning disability and various other things. Pray for the day I could get a multidisciplinary team, albeit online, just talk all of them, putting in their kind of, that would be wonderful. Instead of me having to go here, there, and everywhere. Something a chap on the left there who's holding his camera up, and I discussed at the last one of these about 2 years ago. Healthcare coordinators, which could perhaps be going forward, something that could, people who could be employed maybe by primary care networks. I don't think GP practices could afford it, but PCNs could. Looking at, you know, and helping vulnerable people through the absolute maze that is the NHS system. People like, you know, people with dementia, people with learning disabilities, people with mental health problems, who on their own can't do that. And these would be professionals. At the moment, parent carers, non-paid care, we have to do it. But how, you know, who says we know what we're doing? And we don't, to be perfectly honest, we just play it by ear. I think that's about it. You mentioned something. Do you want to about consultants?
Well, it was just really about, so I'm a physio from Preston. So commonly I find that GPs may say that the consultant's in charge of a condition and not want to take authority for medication that's under maybe the consultant's decision. I don't know if that's a fair comment. That's something I've come across a little bit. So yeah.
Yeah, there needs to be clearer lines of accountability and collective decision making. I guess.
Yeah. Finally, if I could just say, Tony, we decided we need to change the name of this theme. Although my right decided, she made the suggestion. Holistic, person-centered, integrated support. Wouldn't that be wonderful?
Okay, write that down. Great. Okay, so was there any conversation about this? And any final comments anybody would like to make on what they've heard or anything they was discussed on their table that they've got to mention?
Just a question for you, Tony, in terms of the information that we've all fed in today. What are you going to do with it? Oh.
No, not at all. So we our initial idea was to just try and get some sense check from back from as to whether we were still barking up the right trees, and suggest and I think the answer to that is clearly yes. But at the moment we've still got very much headlines, and we're kind of emerging from COVID. We're hopefully going to have a bit more headspace to get some groups together to fine tune and address the things that are coming out of today, because we need some structure to help us deliver on these things. We can't just continue to talk about them. Thanks very much for your contribution.